So with that, we move on to the third presentation, which is going to be by Dr. H. Ramesh from Lakeshore Hospital. And the chair for this session will be Dr. Sujoy Paul, who's a professor of GI surgery at AIIMS, New Delhi. Over to you, Sujoy.
Thank you, Dr. Kapoor. It's a pleasure to be part of this surgical festival. And it's my pleasant duty to call upon Dr. H. Ramesh from Lakeshore, Kochi, who is almost synonymous with the surgery for chronic pancreatitis in our country. And Dr. Ramesh will be talking to us about what is the association between chronic pancreatitis and pancreatic cancer, which is an important thing at the end of the day. Dr. Ramesh, please.
Thank you, Sujoy. Am I audible?
Yes, yes.
Yeah. Thank you, Sujoy, for the kind introduction, and Vinay for the invitation. And congratulations to you on this really splendid initiative of educating all of us. I wanted to address this by asking myself 8 questions. First, is chronic pancreatitis pre-malignant? And from 1992, from our center, a year later from Chennai, and in 1993 from Albert Lowenfeld's International Pancreatitis Study Group, it became clear that the risk of cancer in chronic pancreatitis, regardless of etiology, was substantial. And in fact, this has been further emphasized by recent publications in the last 5 and 6 years, which showed a 8-fold increase in risk of pancreatic cancer. So let's start by saying that, yes, if you have a patient with chronic pancreatitis, we must remember that they may have cancer. India is a low incidence country for pancreatic cancer. And now that means we are now a high incidence in this group. We also understand that metaplasia and dysplasia are steps in the progression, and this demonstration of worlds of chronic pancreatitis and atrophy glands, cancer, and dysplasia in the same specimen came from Dr. Pushpa Mahadevan in our center some 30 years ago. The second question is, can we reliably distinguish inflammatory mass from cancer in chronic pancreatitis? Sadiq has already given us a very thorough insight into this, but all we can do is try, and we can use all of these methods, all of which have been emphasized. But I wanted to further say that one of the reasons why biopsy is negative is because the cellular yield of this pancreatic cancer lost within the worlds of chronic pancreatitis fibrosis is less. And so several passes are required. Rapid on-site mounting is mandatory, and a skilled pathologist is absolutely paramount. Again, because the imaging is not foolproof, that's why centers like Just One's and ours have to resort to many, complicated, seemingly regression equations to try and nail down the risk of cancer or in a particular mass. But why is it so important to distinguish inflammatory mass from cancer? And it is very important because if I would have a benign case, I would do a conservative operation like a fry. And if it's a malignant case, I would like to do a radical operation, which is a pancreatic duodenectomy. And the 3 possibilities that I see are that you may have a histologically proven cancer at the end of this preoperative algorithm. And then, of course, you can go ahead and do a pancreatic duodenectomy. The clinical radiological lineage findings of mass-forming pancreatitis are present. Then if it's clear, there's nothing to suggest malignancy, then you can do a Frey procedure or equivalent. And if it's indeterminate, you could do an intraoperative transduodenal true-cut biopsy. That does work, Dr. Puneet. The true-cut biopsy is fairly good yield, and you can proceed with the resection with a reasonable confidence of having done a cancer operation. So I would like to avoid Whipple resections for benign masses and a Frey procedure for cancer. Why not resect all the masses? If a mass is a cancer, and the decision to resect would have been vindicated, but the median survival is only 30 months. If the mass is a mass-forming pancreatitis, on the other hand, the patient would live longer, but as a pancreatic cripple with pancreatic functional deficiency and poor quality of life. In our country, we don't get outpatient pancreatic enzyme therapy support by insurance, and so it's a real problem to manage these patients. And I wanted to just mention this paper from Yogesh's parent unit in Hamburg, where the survival among patients who underwent pancreatic duodenectomy for chronic pancreatitis at 15 years was substantially lower than those who underwent a more conservative operation. So there has to be a keen desire among patients, among doctors, to try and nail down the benign cases and not do resections on all of them. Our own data showed that the pancreatic function worsened so much that only 47% had a good quality of life, whereas 3/4 in the cord group. So is there an imaging finding which could be pathognomonic? Actually, I have a very contrary view to what Sadiq said. Sadiq talked about hypo-enhancing area in an enhanced gland. I tend to think that there is an atrophic gland in chronic pancreatitis, and if there is enhancement within the atrophic gland, as you can see here, or if you can see this small enhancement here, this was actually seen in Puneet's old department and then advised surgery, but the patient went away to another hospital, that is to us, and then we resected this gland, and this was adenocarcinoma. As opposed to a homogeneous or heterogeneous equally enhancing gland, which is typical of chronic pancreatitis, I would tend to say that this is a very pathognomonic sign. Hypoenhancement can actually be because of inflammation, because of edema, and because of so many other reasons. I'd like to now summarize the data of our experience with cancers and chronic pancreatitis and summarize them in two groups, up to 2001 when there were 74 patients, and then up to 2017 where there were nearly double. And I'd like to rest some of the myths that treatment is so ineffective. The philosophy was very nihilist in the beginning, that there was going to be no real benefit, but it changed to being more activist as we went along. A preoperative biopsy showed cancer in only 1/4 of the patients in the first group and close to 50% in the second group. Even that was not good enough, and now we are much better than even that. In the remaining nearly 90%, we were able to nail down the diagnosis by an intraoperative biopsy, and post-operatively detecting cancer in the activist group happened only in 3%, three of cases, that is 2.3%. But remember that chronic pancreatitis is such a nasty piece of action that you can actually miss the cancer altogether and diagnose it a year later when they have metastatic disease. So when you did resection, and we used a slew of resections with additional organ resections, we found that 80% resectability in the second group, as opposed to 1/4 of the patients being resectable. And that was statistically significant. And the morbidity and mortality was similar. In fact, there was no mortality in the second group. The hospital stay was less in the second group. And the R0 resection increased dramatically from 50% to close to 80% in the second group. And that translated to survival in the second group. That survival after Whipple resection was 28 months median, whereas in distal pancreatectomy, obviously, the results were much poorer, and survival after palliative procedures was really poor. So, and the really significant finding was R0 resection as a important factor in multivariate analysis. So, if you can do an R0 resection, and if you try, you can produce good results compared to even de novo pancreatic cancer. Question number 7, can we try and diminish the risk of cancer? We can and should do hereditary pancreatitis surveillance, but I would like to extend it to other types as well. And our current policy is to counsel patients to look for change in type of pain, worsening or development of diabetes mellitus, unexplained weight loss, and of course do laboratory tests like CA19-9 for whatever it is worth, and 6-monthly ultrasound. It may seem a little, this is a ethics committee approved prospective study, which I hope will show some positive results. Can you prevent cancer by earlier intervention? This is the paper which was discussed briefly by Adarsh and I think Vinay. This is the retrospective analysis, multi-center from Japan. I would like not to discount any Japanese data because it is so carefully collated. And the opinion yesterday was that it was probably not reliable. But please notice that only 50% of the patients underwent resection of the gland. The remaining 50 actually underwent drainage procedures. And yet, I'm sorry?
Cancers were higher in those where surgery was not performed.
And actually, you found that where the surgery was not performed, cancers were much higher than in those where surgery was performed. In addition to that, this escape randomized trial, the fact that there is definitely some likelihood of improvement in pancreatic function after either endoscopic or surgical drainage, and the fact that pain is such a debilitating symptom, which even leads to, in many of our patients, suicides due to pain, the cost of newer insulins, and the functional deficiency, and the large amount of pancreatic enzyme replacements, and the vicious cycle that it places them in, I might consider a gradual change from the policy of let patient earn intervention, which is the policy in many, many centers, and including ours, to I'm moving gradually towards offering intervention earlier in a symptomatic patient. Please remember, the fact is, the bottom line is that only 8 out of 2,200 operated patients who have been followed up 100% have shown up with cancer, and that's a significant achievement. So I would like to conclude by saying that chronic pancreatitis is certainly pre-malignant. Despite advances, we cannot yet make an accurate differentiation between inflammatory mass and cancerous mass. And really, when the doubt is extreme, one has no choice but to resect. But if you resect every one of them, you will leave patients with pancreatic, exocrine, and endocrine insufficiency, which is worse than death in many situations. If you are able to do the difference, it can really make a difference in strategy. If you see enhancement in an atrophic gland, please think cancer. Arterial resection of chronic pancreatitis cancer improves survival. There is some indication that surveillance will help. At least our preliminary data suggests that. And cancer may be preventable by early intervention. And since I've finished well in time, I'd like just to say, in response to some of the issues that was mentioned yesterday, that we have to treat patients based on symptoms. If they have no symptoms, they merit follow-up and medical management of diabetes or steatorrhea. If they have pain or complications, they need imaging to know what is going on. And we have to treat patients based on symptoms and not on the morphology. Regardless of whether they have duct dilatation, duct narrowing, whether they have mass lesions or no mass lesions, whether they have ductal disruption. It is not, that is just a guide to treatment, but it has to be based on the symptoms of the disease. And the third 3-millimeter duct is eminently drainable. And the numbers are increasing because I think 20 years ago, less than 5% of patients had undilated ducts. But now 15 to 20% of patients who present to our clinic have undilated ducts, and they have intractable pain, and they deserve treatment. Thank you very much for your attention.
Thank you. Sujay.
Thank you, sir, for making this complex subject so clear and concise according to the stepwise questions that you have answered. I would, of course, open your talk for discussion to the House. I just wanted you to shed some light on the surgical problem which can happen in patients who have pancreatic mass, along with splenic vein thrombosis and collaterals around that area. Whether those are situations where you should be very clear upfront what exactly you are going to achieve before ending up doing a hazardous operation.
I think if I have a patient with portal hypertension in chronic pancreatitis, and if cancer is not on our diagnostic list, then the attention will be turned to first obliterating esophageogastric varices so that you don't have a postoperative bleed, and then determining from the morphology of the gland what type of treatment would be suitable. Sometimes the amount of collaterals is such that, and the type of collaterals is such that, as Jacob Isbicki's unit showed, that a Fry procedure can be extremely hazardous and and may end up risking the life of the patient. In other situations, we've had and I'm really sorry that I didn't publish it, but we have had patients where we had chronic pancreatitis, and we have a plethora of collaterals thanks to portal vein thrombosis. And when we ligated the gastrocolic trunk, when we put a ligature on the gastrocolic trunk, the portal pressure rose abruptly. And so we had to do the anastomosis in 2 sections, one in the head and one in the tail, the same jejunal loop, but we left the bridge of tissue with the duodenal artery and the gastrocolic trunk. This is just to say that you have to tailor treatment. Sometimes you may have to just stop with the lateral drainage, and that's about all you may be able to achieve. And that may or may not be adequate. But yesterday there was reference to doing a shunt and then to do a surgery for chronic pancreatitis. The most common shunt which in India we are familiar with and we are reasonably good at is the linear shunt. And that's simply out of the question in this situation. To do a makeshift shunt and then trust it to last for some time and then do a chronic pancreatitis surgery, it seems quite a difficult task. If the patient comes with acute pain, I would place a nasojejunal tube, allow the patient's inflammation to settle, CRP levels to come down to normal, and then cautiously operate this patient with one patient on that table. It's usually doable. It requires patience and care.
Thank you.
Sujay, I'll take questions which the students have asked on the chat.
Yes, sir.
Yeah. So there is a question which maybe Dr. Ramesh can take, although it was addressed to probably Sadiq, that we have a malignant head mass and there are calculi in the duct with underlying chronic pancreatitis. So after resection, what do we do to the pancreatic duct?
It is our policy to always lay open the pancreatic body and tail and clear the calculi and to do a side-to-side pancreatogenostomy instead of an end-to-side pancreatogenostomy.
And is there any special surveillance strategy?
I have one more thing to say, that one of the critical issues there is that your jejunal loop, the vascular ligation must be done carefully because you need a much longer end of the jejunum to reach the tail. And if you have been careless, you may not be able to, in an obese or a patient fat-laden mesentery, to go back and revise your length of the end of the jejunum. So you must take care pre-operatively, intraoperatively. I don't think we have a surveillance strategy except to do ultrasounds and CA99s. Neither of it is effective, but for cost reasons, it is not justified. Clinical history, as Dr. Sadiq emphasized, is very critical. When patients are seen in a clinic, they have been seen by the same doctors. They analyze the symptoms, change in the body weight. If you have a change in the body weight, you have to see whether the patient's diabetes worsened. Why did the diabetes worsen? Because of poor care, or was it some other reason? So your flag goes up to know whether you have a malignancy. But if the diabetes remains stable, a new pain has appeared, then think cancer, do a cross-sectional imaging like a CT scan, contrast-enhanced CT scan.
So I'll ask one of my question and then Arun has raised a hand. So do you have data that if you operated on 100 patients with very inflammatory mass and did not do resection, in the follow-up, how many turned out to be malignant?
We looked at the data and published it in Indian Journal of Gastroenterology. We had 7 patients in that group. I think the only the corpus of the patients I can't remember exactly, but it was under 1,000. So it was not a large number because we are obsessed with cancer. We are doing so many tests before, and surveillance, as Puneet has mentioned, only helps the radiologist. It helps the clinician as well, if you like, Puneet, since you are so much into economics of healthcare. But when I am the patient, I want my pancreas looked at, and I have no problems, cost or no cost. I think every life is important, and I don't take a socialistic approach to healthcare. It's not acceptable. So it's about 7 patients is what we got. And after that, we've had an additional patient in whom, after the resection, even the head resection produced foci of cancer. But that was probably a curable resection.
Arun?
That was a patient whom we plan to do resection in any case.
Sir, one comment and one question. Comment is to echo H. Ramesh's point on contrast-enhanced CT. Suppose it's a very bad pancreas, as evidenced by it's a bag of fluid, pancreatic duct just border, and rest everything is replaced by fat. And if you see islands of so-called normal pancreas in otherwise non-CCP patients, that area should be viewed with caution. That area, we would say from the Trivandrum experience, that should be proved to be cancer unless proved otherwise. So even a normal appearing area in otherwise completely fatty replaced pancreas is a dangerous point to suspect cancer. Second question is, sir,
I would like to agree that it's not normal for patchy. It's not a Crohn's disease of the pancreas. You don't get a patchy kind of atrophy. If you get atrophy, it's pretty much at least a major section of the gland. So if you have islands of atrophy, I pretty much say that there must be something wrong there. Something is going on.
Sir. And my question is, is there any screening program to proactively find out development of cancer in chronic pancreatitis with long-term follow-ups? CA19 ultrasound.
Nothing has been published. We are accumulating the data. We haven't got our results yet. We haven't interim studied them, but we have only detected 8 in our post-operative group, and this has been applied to our post-operative group after surgery for chronic pancreatitis, and that's not probably the best way to study the disease. You had to study even the non-operative patients, and I don't see those patients on a regular basis, except those which came to my clinic.
Because in HCC, we have alpha-fetoprotein ultrasound like that, but anything for chronic pancreatitis?
Not yet.
Dr. Ramesh, there are 2 questions and comments in the chat. Maybe you can take them.
I'm sorry.
Yeah, limited head coring, as you said, and limited length of duct opening in case of collaterals around the pancreas. So will it be adequate drainage surgery? Somebody.
This is the extreme conundrum. And you have to, I always talk about doing the best operation in the first up. But if you don't succeed in doing that, then I guess you still want to win the battle, if not the war. Yeah. So you would have to say it is adequate drainage. Dr. Vinay, would you allow me to just present a set of 4 slides, a case capsule, which would be illustrative of this?
Yeah, we have 7 minutes. So we'll leave 2-3 minutes for Sujay to make some final concluding remarks. Yes, please.
Please go ahead.
I just like to have 1 minute. I can.
Sure.
Is there another question? It's in another presentation, so I'll need a minute.
Yeah, and the other question is, if at all you do a shunt, then interval between shunt and pancreatic resection surgery.
I have never done a shunt. In fact, Dr. Puneet Dhar has suggested that we should actually do a makeshift shunt and do the pancreatitis drainage immediately. I think that's a thought, and I might want to consider it. But I think I'm quite confident that with patients and industry, I can actually get there even without the addition of a shunt. Just give me a minute while I get that. This is very.
So in the meantime, you want to.
I think the question that the person wanted to know, what would be the gap if you're doing it for any surgery to reduce the portal pressure? Conventionally, you do wait for about 3 to 6 weeks.
Yeah, I've always been concerned about that, Puneet, because by the time you wait, you end up, having a shunt thrombosis.
Exactly.
You're pretty much back to square one, isn't it?
Exactly.
My feeling is that if you're actually tackling the kind of portal hypertension which develops with chronic pancreatitis, it's mostly left-sided or sinistral. So, I mean, one option is to do a splenectomy and a devasc if that is an issue, and that might lead to reduction in the pressure in the collaterals. Well, I think in
1/3 they do have portal vein thrombosis as well, and those are probably the it's not just somebody's written in that limited frame.
Those are the problems where you obviously a shunt, I don't think will be of help.
But any one of you, have you had to abandon a proposed pancreatic surgery because of extensive collaterals because of portal hypertension?
Yes, sir.
Yes.
I've had many.
I've had that as well.
Acute inflammation as well.
I can also join
this is what I want to tell the young colleagues in the audience, that if you find extensive collaterals rather than bleeding the patient to death, it is a wiser judgment to retract and try some other modality of treatment.
There's one question.
This is as a surgeon also coming from I can say, despite the early results,
you are not clearly audible. Please speak.
Now is it better?
Yes.
Is it better?
Yeah, go ahead.
Okay. I mean, we have published from Hamburg, as Ramesh also quoted, on chronic pancreatitis and portal hypertension. I think 2 or 3 papers in total. But after 20 years of experience in the center, I must say that nowadays I would look at the scenario a little bit different. And this is maybe a true field where we should retract and leave the treatment to the gastroenterologist or medical doctor, because this is severe morbidity we are talking about, especially when we are aiming for preserving operations and not resectional. If you have isolated superior mesenteric vein or portal vein occlusion, fibrotic occlusion, where you still have the option to reconstruct the portal flow either with interposition or a graft prosthesis, then you may consider to do a risky operation with still high morbidity and reconstruct the portal vein. But everything else with in combination of shunt procedures and organ preserving, I personally would not propagate this.
Yeah,
with
but
my experience.
we have some substantial experience, Yogesh, with chronic pancreatitis and portal hypertension, and it's quite quite extreme portal hypertension, if you like, and the results haven't been as bad as you might imagine. So there is the one extreme that you may have to back off from the case, as Vinay said. But I just want to take you through this one case of a 37-year-old housewife.
Ramesh, there's a couple of questions in the YouTube channel. One is it necessary? I think they're fairly quick, so you can just quickly run through them. Is it necessary to continue PERT after resection procedures?
Absolutely.
Second is pancreatic head malignancy with CCP. If it's borderline resectable, role of NACT.
Well, if it's borderline, I don't think it'll be borderline resectable. It'll be unresectable probably, because it's so difficult to diagnose. And I just want to touch upon what Dr. Sadiq said, that we have found that in many patients, infiltration of the vessels does not necessarily mean even malignancy, because extreme inflammation can actually mimic teardrop effect as well as even encasement. And then finally, the histology is benign. So I don't know how to answer this question. I don't know how to 100% diagnose cancer in the first place. So I can't talk about borderline resectable pancreatic cancer.
Yeah, true infiltration in malignant cases you have where you have at the cross-sectional even more than 100 degrees of encasement. True infiltration is proven pathological only in less than 1/3 of the cases. The rest is just inflammation, desmoplastic reaction. This is from what our case studies in Hamburg have shown.
Yep.
So not everything we see as encasement is tumor.
So Puneet, is it okay to go on with this for 2 minutes?
Quickly, very quickly, please.
Yeah. So 2007, limited head coring was done because the surgeon did not feel that it was necessary to do more. Again, a lesson in retrospect. In 2010, the pain came back, and this was the cross-sectional image at that time. You could see a residual head mass with enhancement, and there were extensive calculi as well. She soon presented again with a huge cystic lesion like this. And we had no clue what this was initially. After figuring it out, we realized it's a jejunal loop, which is actually obstructed. And you can see that this is a descending jejunal loop which had been caught in this inflammatory process. And we could have sworn that this is malignancy. Several shave biopsies, true cut biopsies were done. And when we aspirated the cyst, we had actually, this was a cystic, if you like, a jejunocele because of the pancreatic fluid. And then we just did a site-to-site anastomosis to another roux-y segment of jejunum. The pain disappeared temporarily, but later on the patient presented with biliary obstruction, which is quite logical because the patient had such extensive disease. Plastic stent, reoperation, frozen upper abdomen, and these are surgeons with extensive experience in pancreatic surgery. Several biopsies, percutaneous, EUS, open, all negative, metallic stent, tissue ingrowth into metallic stent, as you can see here, and then plastic stents inside metallic stents. So if you have a benign disease where you place a metallic stent, then you really have trouble. And in July 2013, she went off to the Gulf because she wanted to join her family. And there she kept neglecting her disease. We kept telling her that probably she requires a reoperation and probably a Whipple or probably something definitive, even though it is going to be technically difficult. But then she presented with septic cholangitis. She was airlifted from the Gulf and died despite aggressive intensive care. Postmortem, we took the permission of the family to do multiple biopsies from the pancreas, no malignancy. So much for our erudition as far as what we can do. The model of the story, I feel, is that we should try and do an adequate operation the first time, even in portal hypertension, if we can.
Thank you, sir.
Sujoy, any concluding remarks, please?
Very quickly, I would just briefly run through what has been said. Basically, the fact is that chronic pancreatitis is a risk factor for malignancy, maybe to a lesser extent in our country than the Western world. And there are not many foolproof methods available for us to screen people so as to avoid malignancy. But as Dr. Ramesh has repeatedly pointed out, that the first attempt to approach these patients has to be done on the background of a properly evaluated clinical history and having done the investigations properly. And the first approach has to be the best approach so that the patient in the long term doesn't keep suffering from the thing. The other thing which came out was that resection not necessarily is associated with good results in the long term. They can lead to a decreased quality of life, and some studies have shown that the mortality increases at the long term. And so portal hypertension with chronic pancreatitis is a difficult problem where we don't have many answers, but a lot of questions. But even then, there are instances where you can get away with a lesser procedure without causing catastrophic bleeding. With that, I will hand over to Dr. Kapoor.
Thank you. Thank you, Dr. Ramesh. Thank you, Sujoy.